All right, folks, welcome to the lecture on the special senses. This is going to focus on primarily sight and hearing, but we will talk a little bit about all of your senses, including taste and smell at the end. Our objectives for the lecture: this is everything that you should know to do well on the quiz and for the final. So your main senses and your special senses: obviously, vision receptors in your eye, hearing receptors in your ear. The other sense you find in your ear is equilibrium. This is just your sense of balance. Gustation is our scientific term for the sense of taste, and olfaction is the scientific term for the taste of smell. I would know the definition of both of those words for the quiz. And then you have your general senses. This is stuff like pressure and temperature and pain from your receptors in your skin. And then also this sense of position, kind of a mental map of where you are in space from all the receptors in your muscles and your tendons and your joints. We call this proprioception. And again, this is just how your body knows where you are. If you raise your right hand, this is how your body knows that your right hand is raised. Some key terms here that refer to our senses, just our senses in general. We're going to start with the sense of hearing and start by looking at the anatomy of the ear. So there are three sections to the ear: the outer, middle, and inner ear. The outer ear is what you usually think of when you think of the ear. The ear that you can punch holes in to put earrings in, or the ear that your mom grabs when she's mad at you, as well as the ear canal. The middle ear is three tiny little bones called ossicles and your eustachian tube. And then the inner ear is where all the magic happens. These are where your sensory receptors for both hearing and balance are found. So here's what I'm talking about when I talk about three divisions of your ear. We'll look first at the outer ear. The outer ear, the part that you think of when you think of the ear, this guy right here, is called the pinna, or he has two names, the auricle. Both of those refer to the ear that you can grab, that you can touch, that you can put earrings in, all of that. The other part of the outer ear is this then external auditory canal, where you put your Q-tip when you're cleaning out your ears. And the external auditory canal ends at the tympanic membrane. This is more commonly called your eardrum. As sound waves enter the ear, they push up against the tympanic membrane and cause the tympanic membrane to vibrate back and forth. That vibration is then transferred to the middle ear. The middle ear has three tiny, tiny little bones called ossicles, and those little bones vibrate back and forth as well, and they transfer that vibration into this little device right here called the cochlea, which is in your inner ear, that's going to turn those vibrations into electrical signals. So looking a little more in detail at the middle ear, you find these three tiny little ossicles here: the malleus, the incus, and the stapes. They get their name for what they're shaped like. The malleus looks like a hammer a little bit, so the malleus is the hammer. That's what malleus means. Incus means anvil, what you would use to make, I don't know, horseshoes. And then stapes means stirrup, which frankly I think is the only one that actually looks like its name. These little bones vibrate back and forth. The stapes, or not the stapes, the malleus is attached to the tympanic membrane, and as the tympanic membrane vibrates back and forth, it pulls on the hammer, which pulls on the anvil, which pulls on the stirrup, and then transfers sound waves, those vibrations, from the foot plate of the stirrup into the inner ear. And I'll show you how that works in a little bit. The other thing that we find in the middle ear is this auditory tube or eustachian tube. And this connects the middle ear to the nasopharynx. It comes out kind of below your nose into your throat. The auditory tube has a few purposes. Its main purpose is to make sure that the pressure in the middle ear and the pressure in the environment are the same. This is why your ears pop when you are going up in the airplane or landing in the airplane, or when you're driving up into the mountains, or if you watch that SpaceX rocket launch, those two astronauts in there most definitely had their ears popping. Your middle ear is contained entirely in bone, and then it has the tympanic membrane in front of it, so it's essentially sealed off from the environment. And if it was just sealed off from the environment and left there, then whenever you had changes in pressure, that would put pressure on the tympanic membrane, cause it either to bulge out or to be kind of sucked into the middle ear. And either way, that would be incredibly painful. So we have this auditory tube that travels from the middle ear to kind of back behind your nose. And every time you swallow or yawn or talk, that auditory tube opens up and equalizes the pressure between the external environment and the middle ear. The other purpose of the auditory tube is for drainage. And if you've ever had an infection in your middle ear, otitis media, you know that that eustachian tube can sometimes get blocked, and then fluid can build up in the middle ear, and that can be very, very painful. We'll talk about otitis media a little later on. So here are our little ossicles. We see here the malleus, the hammer, the incus, the anvil, and then the stapes, or the stirrup. And you can see how the malleus is attached to the tympanic membrane. The inner ear is this little organ called the labyrinth. It's got a couple of different parts to it, the cochlea and the semicircular canals. The labyrinth is filled with fluid, and the device for hearing is called the cochlea. The organ of Corti is the specific part of the cochlea that turns vibration into electrical signal. The vestibular apparatus is the semicircular canals. This does your sense of balance. So that's where we find both of them right next to each other. And then all of this is carried by the vestibulocochlear nerve, which is cranial nerve number 8, I believe. Also called the auditory nerve or the acoustic nerve. It has two branches, a cochlear branch for your hearing, a vestibular branch for your balance. So here is that whole labyrinth. You can see this part right here, the cochlea, not Coachella, cochlea. The cochlea, this comes from the Latin word snail, because it looks like a snail shell. Within the cochlea, we find the organ of Corti, which is this little section right here. These are tiny little hair cells. They're not actual hairs. They're just long, thin cells that look like a hair under a microscope. And as fluid moves back and forth in the cochlea, that moves these little hairs, and they trigger an electrical signal. So fluid moves back and forth in the cochlea and in the labyrinth via this oval window right here. So remember the stapes sat right on top of that? The footplate of the stirrup was right over there. As the stirrup vibrates back and forth, it pushes on the fluid in that oval window, and that causes waves in the labyrinth. And then that fluid waves back and forth, and that's what causes the movement of the hair cells and then the electrical signal. If it helps, think about the last time you went to a water park, Water World, Elitch's, wherever, and we're in the wave pool. Your inner ear is essentially a glorified wave pool. The footplate of the stapes pushing against the oval window causes waves in the cochlea and in the labyrinth. And that's how those hair cells move back and forth, and that's how we trigger electrical signals from your hearing. Some combining forms that refer to the ear and to how you hear. Audi and Osco, both of these refer to just hearing or sound in general. Maringo refers to your tympanic membrane, as does tympano. I would know both of these for the quiz. Salpingo is just a tube in general. When we talk about salpingo in this lecture, we're talking about the auditory tubes in your ears. And then we have stapido to refer to the stapes, labyrintho for the labyrinth, vestibulo for the vestibule, and cochlea, obviously, for the cochlea. Some term words here that would be good to go over for your quiz and for your homework. So let's talk about some clinical stuff that we see with the ear. Hearing loss can occur for a number of different reasons. You can see damage to that vestibulocochlear nerve or to the pathway that it takes through the brain. That will cause hearing loss. This can be hereditary. Sometimes toxins will damage that nerve. If you're exposed to a lot of loud noise consistently, that will damage the nerve. Maybe you work on a construction site and you work on a jackhammer all day, every day, and you have very poor hearing protection. That would be constant loud noise over a long time that would cause damage to that cranial nerve. And then just as you get older, stuff slows down, and your cranial nerve that does hearing is no exception. Treatment for sensory neural hearing loss is a cochlear implant. This is you've probably seen it, little round implant that goes on the outside of the skull. And then you feed sound into the nerve past where the nerve is damaged to go right into the brain. Very common treatment for a number of different types of hearing loss, and usually pretty successful. Conductive hearing loss happens when you cannot get sound into the inner ear. And there are a few things that can cause this. Usually it's pretty easily fixed. It could be obstruction. Maybe something got in your ear. Maybe you're dealing with a little kid who's sticking stuff in their ear. A very severe infection where the middle ear is full of pus and the bones in the middle ear can't move back and forth. And then sometimes you'll see the bones of the middle ear will fuse together. And then you'll have to go in and replace them with a prosthetic bone. Usually this can be very easily treated. You just have to figure out what's going on. Clear up the infection, get the Barbie doll shoe out of the kid's ear, whatever it may be. Otitis refers to inflammation of the ear. Most common type is otitis media. Media here, this is just our Latin word for middle. So otitis media, inflammation of the middle ear. In otitis media, you usually see the eustachian tube get kind of swollen and blocked. And so you see this buildup of fluid in the middle ear. And with that buildup of fluid, a buildup of infection as well. Treatment for this, usually antibiotics, will clear up the infection. If you have a patient who has chronic otitis media, they're just constantly getting ear infections, you may go in and put tubes in the tympanic membrane. You stick tiny little tubes in the bottom of the eardrum that will allow fluid to drain out through the auditory canal in case the eustachian tube gets blocked again. This is a pretty common procedure. You see it done a lot in little kids. Eventually, those tubes will fall out as scar tissue grows over where they were put in. The other thing that might be considered is maybe removing the tonsils, because the eustachian tube empties into the throat pretty close to the tonsils. So if you have constant infection in the tonsils, it's easy for that infection to go back up into the middle ear, and then for that infection in the middle ear to kind of go back into the tonsils, and you have this infection constantly repeating itself. So you will see that sometimes in very chronic, severe cases of otitis media. Otitis externa is inflammation of the external auditory canal. We get a lot of pretty pictures in this lecture. They also call this swimmer's ear. This can be either fungal or bacterial. You just see it in people who always have a wet ear, so swimmers. If you live in a really hot, humid climate, you see this when the ear canal is not allowed to dry properly. And you can see, look at how swollen the ear looks right here. And of course, all of that nasty discharge coming out of the ear. This is pretty easy to clear up. You'll give antibacterial or antifungal drops in the ear that will clean the infection out, and then just making sure that the ear stays as clean and dry as possible. Otosclerosis happens when the little bones of the middle ear start to deteriorate. You see it a lot of the stapes, excess bone growth on the stapes for some other reason. The cause is not well understood. However, it's pretty easy to treat. You'll go in and do a stapedectomy, and that suffix ectomy should be something you're familiar with right now. This is to go in and remove something. So you'll go in, remove the stapes, and then you'll put in a tiny little prosthetic bone. And usually this has a very, very good outcome. Meniere's disease happens when you produce too much fluid in the inner ear. For whatever reason, you get this very high fluid production, and then this leads to lots of feelings of pressure, dizziness, sometimes tinnitus, get this kind of ringing in the ear, or hearing loss, sometimes nausea. Treatment for this, because the cause is not well understood, the treatment is not super great. There are medications that can help with the nausea and the dizziness, but if it's a very severe case of Meniere's disease, you may have to go in and actually destroy either the inner ear or that 8th cranial nerve to get relief from the symptoms. Now, if you destroy the 8th cranial nerve, what's going to happen to your hearing in that ear, though? Right? You're going to lose hearing and your sense of balance on one side of your body. So this is only done in severe cases. An acoustic neuroma or a schwannoma happens when you get a tumor on the 8th cranial nerve. And that's what we see in this picture right here, that little bump down there at the base of the brain. Signs of this will be kind of similar to Meniere's disease: tinnitus, dizziness, gradual hearing loss, and then as that tumor gets bigger, it's going to engulf other cranial nerves, and you'll see other weird symptoms and side effects, maybe difficulty moving your tongue, or lack of sensation on the face, or the salivary glands won't work properly as the cranial nerves that control them get consumed by the tumor. Obviously, this will have to be surgically removed, and obviously that's going to be tricky because there's a lot of stuff, very delicate stuff, in that part of the brain. Some more key terms here, discussing some of our diseases that we see of the ear. And now let's get into the eye. These are talking about stuff external to the eye. There are a few that you should, again, definitely know for the quiz. Blepharo and palpebral both refer to your eyelid. Anything with dacry or lacry refers to tears or to your tear ducts or your lacrimal sac. Obviously, opto, oculo, ophthalmo, all three of these refer to the eye. Sclero to the sclera of the eye, corneo to the cornea. We'll talk about what both of those are. Keratosis also refers to the cornea. I would also know that for the quiz. Lenti or lentil to the lens, as does phaco. We have two words for lens. Uveo is our uvea, choreo is our choroid. Again, we will talk about all of these in a minute. Cyclo referring to the ciliary body. Anything with IR, IRT, or IRD refers to the iris. And then pupillo and retino, hopefully, are self-explanatory. Two suffixes that you should know for the quiz: opsia and opia. Both of these refer to vision. So, humans, by and large, are visual critters. If you think about something like your dog or your cat, when you come home, how does your dog greet you? He probably doesn't look at you. He probably walks around you and sniffs you, smells your pants and your shoes and your hands to figure out where you've been and what you're doing, and also to identify you. Humans, we don't do that. I mean, you might go sniff your roommate when they come home. Hopefully you don't. We are visual, and that's primarily how we get our information. So that means there is a whole lot of stuff in place to protect our eye and keep it from getting injured or damaged. And these include things like your eyelid and your eyelashes that are there to keep stuff from getting into your eye. Your eyebrows, which catch any debris that might fall down into your eye. Yes, your eyebrows have a purpose. Please do not shave them off and draw them back on. They do not provide the same kind of protection. The conjunctiva, which is a little membrane that covers the front of the eye and seals it into the socket. And then all of your lacrimal apparatus. So lacrymo, like I said earlier, refers to anything with tears. Your lacrimal gland is found in the upper outer corner of your eye, and it produces tears that wash across your eye and get sucked into these two little tubes in the inside corner of your eye called the superior and the inferior canaliculi. You can see these little tubes. If you go into the bathroom, peel down the inside corner of your eyelid and take a look, you should see a tiny, tiny hole there, and that is leading into your canaliculi. From the canaliculi, then, tears are going to drain into the lacrimal sac, which drains into the nasolacrimal duct, which drains into your nasal cavity. This is why your nose runs when you cry, or when your eyes get all watery during allergy season, because all of those tears are being drained into the nasal canal. This also makes for some interesting diagnostic techniques that we'll talk about in a little bit. Now, your lacrimal sac is not just making tears, it's also making this enzyme called lysozyme. Lysozyme is made in the lacrimal glands. It's also found in saliva, in breast milk, in mucus, and it's a nice overall antibiotic. And it's there to protect your eyes from bacterial infection. So this picture that you see over on the left here, this is from my microbiology class many, many years ago. We were given a little petri dish and a little test tube full of water that had Micrococcus bacteria growing in it. And we took our petri dish, we swabbed it all over with the water that had the bacteria, and then I had to get a drop of tear from my microbiology lab partner and put a little drop of tear in each quadrant of the petri dish. Getting her to cry was not easy. We told her sad stories. We played sad music. I had her stand with her eye held open. Finally, we just ran the pipette across her eye, and that will make anyone tear up. So we put a drop of tear in each quadrant right here, taped up the petri dish, threw it in the incubator for 24 hours, came back and opened it up, and you can see all these tiny little yellow dots. These are little colonies of the Micrococcus bacteria, and you can see they grew all over the petri dish except where we put a little drop of my lab partner's tears. And that's because the lysozyme in the tears killed off any bacteria growing in that region, so that's why there's nothing there. So like I said, your eye is protected by a whole bunch of stuff. Everything from the bones that surround the eye to your eyelids, your eyebrows and eyelashes, your conjunctiva, your lacrimal sacs, all of those. There are 3 layers to the eye, which I think is kind of nice, just like there are 3 divisions to the ear. The outermost layer is called the sclera, the middle layer is the uvea, the inner layer is the retina. So the sclera is your white part of your eye, or the white of the eye. In the front of the eye, the sclera becomes transparent and makes up your cornea. Your cornea helps to bend light as it enters your eye. Your cornea is one of the things that gets reshaped if you do some kind of laser eye surgery. They'll go in with a laser and change the shape of the cornea to bend light more appropriately. The uvea is the middle layer of the eye. This is your vascular layer. This is where all of the blood vessels for the layers of the eye are found. And there are a few interesting things that we find in the uvea. The choroid, which is that blood vessel layer. In the front of the uvea, we find the ciliary body, which is a little muscle that controls your lens. What does a lens do? Think about the lens in your phone, because no one has a camera anymore. What does the lens in your phone camera do? It lets you focus. It allows for accommodation. This is just focusing on stuff that's near up or stuff that's far away. You can sense this kind of change in your focus. If you look at something that's very, very close for a few seconds, maybe a minute, and then look up at something that's far away, like 20 or 30 feet away, you should be able to sense that little shift in change as your lens goes from looking at something close to something far. As you get older, the lens loses its flexibility. and it becomes harder for you to go from close up to far away very quickly. This is why people will wear bifocals. Part of the glass lens will allow them to look at stuff close up. Part of them will allow them to look at stuff that's very far away. The iris is a little muscular ring, a sphincter muscle, that controls the size of your pupil. The pupil is just a little hole in your eye. I know you hear people talk about going to the optometrist and they dilate your pupil to look at your eye. In reality, what they're doing is relaxing the iris to allow the pupil to get a little bit bigger so they can see the back of your eye better. Your iris is also what gives you your eye color, whether it's blue or gray or green or brown. The innermost layer of your eye is your retina, and this is where all the cool stuff happens. This is where your visual receptors are located. And the cells that help you see are two specialized cells called rods and cones. So rods are most active in dim light. Think about when you get up in the middle of the night to go stumble your way into the bathroom. The cells that are working in your eyes are your rods. So they're active in low light. They have very low visual acuity, which just means stuff is going to look kind of blurry. Think about when you're walking your way to the bathroom in the middle of the night. Things don't have really sharp edges. You usually can't see the outline of objects very clearly. Rods do not respond to color. These guys see in black and white. That's why when you're up at 3 in the morning to go to the bathroom, the whole house looks shades of gray. Now, cones, on the other hand, these are active in bright light, daylight. They give you very high visual acuity, so you get a nice sharp picture. And these guys respond to color. This is what lets you see in different shades of color. Between the two of them, which one do you think humans have more of, rods or cones? We have more cones. We definitely have more cones than rods. Our night vision sucks. Compared to a skunk or an opossum or a raccoon that's digging in your trash, we have very, very poor night vision. We have primarily cones. Something like the raccoon digging through your trash has a lot more rods than we do, so they have very good night vision. They can see well in the dark. So looking back at our eye again, we'll look at our 3 layers. You see the sclera on the outside turning into the cornea when we get to the front of the eye. The cornea is clear. The middle layer of the eye, the choroid, in the front here we see our little suspensory ligaments and little ciliary muscles that help to hold the lens in place and help the lens to focus. You also see the little iris right here, our little sphincter muscle that's going to give the eye its color and that's going to control the size of the pupil. And then the innermost layer, this yellow layer right here, is the retina. There are a few points to point out on the retina. The fovea, this is the part straight back on the retina. This is the place where you have the greatest number of rods and cones because it's exactly behind the retina. If light was going to go straight through the eye, it would hit the fovea. The optic disc right here, where the optic nerve enters the eye, this is your blind spot. You don't have any rods or cones there. So vision requires refraction, which just means bending light. So that it hits the back of your eye, it hits your retina at just the right angle. When that light hits the retina, that activates your little rods and cones, and they send an electrical signal to your brain via the optic nerve, which is cranial nerve number 2. Like I said, the optic disc is your blind spot. This is where the nerve connects to the retina. There are no rods or cones there. The point of greatest acuity, the sharpest, clearest picture, is the fovea, and it's surrounded by this macula that's really, really rich in both rod and cone cells. There are 2 little fluids in your eyeball that help to keep your eyeball nice and round. We Here's our eyeball. Here's our cornea right here. That's unfortunate, but you get the idea. In front of the eyeball, between the cornea and the lens, we find the aqueous humor. This is just a little kind of watery fluid that sits right underneath the cornea and helps keep the cornea sort of puffed out. And then within the actual body of the eyeball, we find the vitreous body or vitreous humor. This is thicker, more like a jelly almost, and it helps to keep the shape of the eye nice and round. It also helps to bend light as it's going through the eyeball to hit the retina. There are 6 little muscles on the outside of the eyeball that help to coordinate the way that the eyeball moves. You have 4 rectus muscles. Rectus means straight, so that's these guys right here. They're going to move the eye straight up or down, straight left or right. And then you have 2 oblique muscles. And these are these guys right here that help to move the eyeball at an angle. If you remember when we talked about Graves' disease in the endocrine system, one of the hallmarks of Graves' disease was exophthalmos. If you remember that picture of our patient with the bulging eyeballs. Exophthalmos occurs because these little muscles right here get inflamed, and that inflammation pushes the eyeball further out of the socket. Some key terms here that discuss the eye and structures in the eye. And let's talk about some clinical stuff. So most of us do not have perfect vision. Most of us need glasses or contacts or have actually gone under the knife for laser eye surgery. There are 2 different kinds of main errors of refraction, either nearsightedness or farsightedness. If you have a myopia, you are nearsighted. Your eyeball is a little too long, so stuff that's closest to your eye is what is clearest. We always remembered in school myopia and nearsighted because M and N are right next to each other in the alphabet. When you have a patient who has myopia, their images are clearest actually a little in front of the retina because the retina is too far away, the eyeball's too long. A patient who is farsighted has hyperopia, so stuff that's far away is clearer than stuff that's near. In this case, the eyeball is a little too short, so images are still fuzzy when they hit the retina. They're actually at their clearest kind of behind the retina. Astigmatism happens when the cornea or the lens have an abnormal curve. Maybe they kind of bulge out a little too much. Glasses and contacts can usually correct just about all of these. And then, of course, there is laser eye surgery, which is used for just about all of these conditions as well. So here's an example of what I mean by an eyeball that's too long or too short. You can see this is normally how long you like the eyeball to be. In myopia, it just goes a little too far. Whereas in hyperopia, the eyeball is just a little too short. Both of these, like I said, can be corrected with lenses that will bend the light as it enters the eye and make sure that your picture hits the retina at its clearest. Some common infections of the eye. I told you we'd have good pictures in this. Conjunctivitis is inflammation of the conjunctiva, also called pink eye. That's what we see up here. Highly infectious, highly contagious, very easily spread from person to person. What causes pink eye? What is the bacteria? Bacteria in question is E. coli, which is found where in the body? What kind of bacteria is this? This is found in feces. And by now I usually have one student who's like, so if I fart on someone's pillow, will I give them pink eye? No, you can't give somebody pink eye by farting on their pillow. This is usually somebody goes to the bathroom, does not wash their hands, touches their face, touches their eyes, and gets E. coli into their eyes. This is one of the reasons why you see it spread a lot in daycares and elementary schools, because little kids are kind of gross. They don't always wash their hands after they go to the bathroom. Fortunately, E. coli, conjunctivitis is pretty easy to clear up. You'll just use sulfa drops in the eye for a little while. Trachoma is a bacterial infection that causes inflammation of the cornea and the conjunctiva and inflammation of the tissue on the underside of the eyelid. This comes from a type of chlamydia bacteria. No, not that chlamydia, but it's in the same family. It's carried by a fly that lands on the eyes, and then the bacteria gets in the eyes and causes this inflammation and this scarring on the underside of the eyelid. And then each time the person blinks, that scar tissue rubs against the cornea and will eventually result in scarring of the cornea and will eventually result in blindness. This is a leading cause of blindness in the developing world. And it's unfortunate because it's pretty easy to prevent. You just keep the kid clean and make sure there aren't a lot of flies around. And there are medications that will help with the inflammation and help to reduce the infection. Ophthalmia neonatorum I have alluded to a few times when we talked about the reproductive system. This is acute conjunctivitis that you see in newborn babies, usually caused by gonorrhea. So mom has an active gonorrhea infection and passes that gonorrhea to the baby when the baby is delivered. And now you can see over here the really bad discharge in the eye. You can see how red and inflamed the eyes are. This is one of the reasons why after that baby is born, you'll put a couple little drops of, or a little strip of antibiotic ointment in the eye to make sure that if mom picked anything up, you get that cleared out and taken care of. Retinal detachment is not uncommon. This happens when the retina separates from the choroid, the middle layer of the eye. Remember, the choroid was the vascular layer of the eye. This is where all your blood vessels are. So if the retina separates from where the blood vessels are, it's not getting any blood and may be destroyed or die. So you need to address retinal detachment very, very quickly. This can be caused by a tumor or a hemorrhage. Most often it's caused by some kind of injury to the eye, blow to the head that causes a tear in the retina. You'll go in and repair that tear with a little laser surgery, and then the fluid of the vitreous body should come back over the retina, and the retina should reattach to the choroid. Usually what will send your patient into the doctor for retinal detachment, they'll start complaining about seeing lots of little black spots in their field of vision. And that's a good indication that something has gone wrong with the retina. Now, after the retina has detached, it's more prone to detach again. So you'll want to make sure your patient's very careful about their eyes not getting blows to the head or blows to the eyes or something like that. Macular degeneration is usually seen just as your patient gets older. Sometimes it can be due to drugs, sometimes it can be genetic. In macular degeneration, you see the macula, which is the point of highest visual acuity, start to just kind of degenerate. It starts to wear away. In macular degeneration, you'll see the central vision goes away, the peripheral vision is not affected. So what you look straight at will look kind of fuzzy and blurry and maybe dark, but your field of vision in your periphery is still normal. Diabetic retinopathy is usually seen with uncontrolled diabetes. You see this buildup of fluids or buildup of sugar and buildup of this kind of fatty deposit on the inside of the retina. And as that happens, you'll see this buildup of blood vessels as well, eventually hemorrhage, and the retina will detach, and then your patient will be blind. This is one of the reasons why getting your eyes checked if you have diabetes is so very, very important, because usually an optometrist can tell if you have early retinopathy, and then you can do something about that. A cataract happens when the lens becomes opaque. This can be due to disease in the eye. It can be due to injury. Chemicals is very common. Maybe you accidentally get bleach in your eyes, for example. Or if you've been exposed to a lot of UV light, you're constantly outside working and not wearing sunglasses. That can cause a cataract as well. Now, the good news is this is pretty easy to replace. You'll go in, remove that lens, and then put in a new prosthetic lens. Either kind of in the front of the pupil or behind the pupil. But this is a very, very common surgical procedure, very easy to do. So this is what you see in different visual disorders. You can see here macular degeneration. The center of the picture is kind of blurry while the periphery looks good. In a cataract, everything just looks kind of blurry because the lens is becoming opaque. In retinopathy, or also if the retina detaches, you see these black kind of floaty spots in your field of vision. Glaucoma happens when you get increased fluid in the eye, and that leads to increased pressure in the eye. That's what we see down here. This is what they test for when you go into the optometrist. You put your chin in the little machine and then they do the poof of air into your eye. What they're looking for when they puff that air into your eye is, does your eye indent a little bit when that air hits it, or does your eye stay straight and flat? If your eye curves in a little when the air hits it, that's good. That means it's flexible. If your eye stays straight, if it doesn't move when it gets hit by that air, that means that there's too much fluid in the eye. You have increased pressure in the eyeball, and you need to treat this glaucoma, because this will lead to damage to the eye and blindness if it's not treated. Treatment for this, there are medications that can decrease the amount of fluid that the eye makes, and then also surgery that will help to drain off that excess aqueous humor as well. So I said there are some interesting diagnostic tests that you can do with the eye. Fluorescein is a fluorescent dye that you'll stick in the eyeball, and it will pool in areas of damage. If you have an abrasion on the cornea, it will kind of puddle in there, and then you'll look at the eye with a black light and see where that fluorescent dye pooled. So that's what we see in our patient right here. You see these big scratches in the cornea where that fluorescein has concentrated. You can also use this to test for tear production, which is what we see in our dog right here. They've taken a little strip of paper that has a tiny bit of fluorescein at the bottom of it, put it into under his eyelid, or holding his eyelid shut, and then for a certain number of seconds you time and see how far up the strip of paper will that fluorescein go, and that will give you an idea of whether or not he's making a normal amount of tears. You can also do this as what they call the Jones test to see if there's a blockage in the nasolacrimal duct. So you should be able to put fluorescein in the eye, and then it should come out the nose if everything's working properly, and that's what we see in our dog there. Color blindness is any inability or decreased ability to see color or to perceive differences in color. There are two common types. The most common, what you usually think of when you think of color blindness, is red-green color blindness. And in this case, either the red or the green cone pigments, or both of them, weren't made or they don't work properly. Sometimes with this, you'll see patients who can detect the difference between red and green, but they can't pick up on different shades of red and green. If you put 12 green things next to each other, they would all look the same color. This is inherited on the X chromosome. This is X-linked recessive. So you see it more in men than you do in women. Blue-yellow color blindness is incredibly rare. And in this case, your patient, like the red-green, either doesn't make blue cone pigments or they're not functioning properly. This one is not X-linked. So you see it equally in men and women, but again, only 1% of the population. This is not a common condition. So this is what red-green color blindness would look like in your patient who was red-green colorblind. That's what we see right there. What number do we see here? Probably you've had a test like this before, maybe in high school or middle school. So you should see the number 29. I have yet to have a student realize that they were colorblind doing this, but you know, anything's possible. For blue-yellow color blindness, you can see our picture's a little better, but it still looks kind of washed out. And then what shapes do we see in here? Hopefully a circle, a star, and a square. Some key terms here and vocabulary for the eyes and disorders of the eyes. Let's talk about our last two senses, your sense of taste and your sense of smell. Your sense of taste is often called gustation. You have 5 taste receptors on your tongue and in your throat and on your cheeks. They're all over your mouth. Sweet, salty, sour, bitter, and then umami. Umami is something that responds to protein. It gives you that kind of full, whole mouth feel when you're eating something with a lot of protein, like mushrooms or meat or MSG in your bag of Doritos. Your taste buds respond to chemical stimuli. When you're eating food, the chemicals in your food attach to either the membrane of the taste bud or they go into the taste bud and they trigger that electrical signal in the taste bud. Your most sensitive of your taste receptors, the one that responds the most quickly, is your bitter taste receptor. And the hypothesis behind that is that most poisons that we find in nature are bitter. So if you are very, very sensitive to bitter foods, that will tell you if maybe something is poisonous. So we've probably all seen the taste bud map where you have like bitter on the back and sour on the side and sweet on the front and there's nothing in the middle. That's not the case. Your taste buds are scattered all over your tongue. There's not one part of the tongue that responds more to them than the other. Your sense of smell is called your olfaction. Your smell receptors, your olfactory epithelium, is located in the very top of your nasal cavity. When you breathe in, that's going to bring air and air-containing odors up into your nose. Anything that causes you to have a reaction is called an odorant. So how this works is tiny, tiny particles of whatever you're smelling have broken off, are floating through the air, and you breathe them into your nose, and then they attach to that epithelium at the top of the nasal cavity. So this means when you walk into the house and you take a deep breath and say, oh, someone's baking chocolate chip cookies, I can smell it. That's because tiny, tiny particles of those chocolate chip cookies have broken off of the cookie or floating through the air, and you just inhaled them into your nose. This also means when you walk into the house and take a deep breath and say, oh, the dog pooped on the carpet again. Tiny, tiny pieces of dog poop have broken off of that, are floating through the air, and you just inhaled them up into your nose. So here's your olfactory bulb, your olfactory epithelium right here, you smelling stuff. Your nose and your mouth are connected, and this has a big tie-in to how you taste and how flavor works. And if we were in class, we'd be doing a fun little experiment with Jelly Bellies. And I don't have you guys in front of me, so go get some jelly beans, and I want you to do this experiment. Like the next time you're at Sprouts, go to the bulk bin, grab a bag of jelly beans, and you'll put just one jelly bean in your mouth, chew it a few times with your nose plugged, don't swallow, chew it a few times, and then unplug your nose and see what you taste, the difference between what you taste when your nose is plugged versus what you taste when your nose isn't plugged. Should be night and day. And the reason for that difference is what we call retronasal olfaction. So when you are eating your food, little odor particles are traveling back up into your nose from your mouth. And it's that combination of taste and smell that makes flavor. And flavor is different than taste. Flavor is why a sweet cherry and a sweet apple and a sweet chocolate bar all taste different, even though they're both sweet. It's those chemicals that you're smelling that make all the difference in the world. This is also why Grandma puts tons of salt and pepper on her food, because as you get older, your olfactory epithelium dies off and stuff just doesn't taste as good as it used to. So speaking of which, so things that you see as you get older, like I said, your olfactory bulb starts to deteriorate, which means food doesn't taste as good. And again, usually you'll see older people will put lots of salt and pepper on their food to try and draw out some kind of flavor. Your ability to control temperature, your perception of pain and pressure will decrease, and then you'll see changes in your eye function, decreased ability to focus. This is, again, why older people will usually need bifocals. Poor night vision, poor depth perception. This can lead to uncomfortable and awkward conversations about whether or not grandma and grandpa should be driving anymore. And then cataracts. You'll see hearing loss as you get older, especially if you've been exposed to a lot of loud noise over the course of your life. And then lots of issues with balance, proprioception, coordination. And this is why older people sometimes fall down a lot, or why you're worried about grandma's balance, just because as you get older, those change. So that is that for the special senses. As always, if you have questions, please stop by office hours or send me an email. And thanks for dropping in.